much for having me, and it's really exciting to see so many people in the same field and rehab in the same room. And this room is beautiful. If you were here a few years ago, I remember teaching in this building and there were cockroaches. It was a mess. So it's quite nice to see this room. It's a tough act to follow, you guys, I must say. And I'm going to speak a little bit about looking beyond the numbers. And what I mean by that is, I think as physicians in HIV care, we've historically been very fixated, like some of our patients, on the numbers, viral loads, CD4 count. And I think that we need to look at the shift, the paradigm shift, to look at more of a holistic approach. And we're fortunate enough to have an interdisciplinary team, clinical setting here at St. Michael's. And we know that HIV has become a chronic, some people say manageable disease. Obviously, when you speak to a lot of people, it's not a great word, and people get offended by that word. But it has become a chronic illness, and we have to look at a chronic disease model. And the focus really has been on an improvement in life expectancy and improvement overall in quality of life. And we need to have a greater focus, greater attention on the management of comorbid conditions, looking at cardiac risk, looking at cancer screening, looking at smoking cessation, and looking at things like screening for mental health and addictions. And these are fairly new terms, in this field. And I remember giving talk a few years ago, and people would get upset when I talked about smoking cessation, for example, because patients would say, "Leave me alone, I have this horrible disease, and let me enjoy my cigarettes." And we know that we need to start doing a better job looking at some of these things. So there's a need for a paradigm shift from acute sort of terminal disease to a chronic disease model, and we need to address medical, psychological, social, and spiritual issues. And the challenge is finding the right clinician, I think, and the adequate time to address the multitude of issues that I'm bringing up here. And so it led us, a few of us, to develop this clinical tool, what we call an HIV clinical checklist, to assist us in looking at a broad scope of practitioners to assess some of these important issues. This was myself, Jeff Cohen, who's a practitioner, HIV practitioner in Windsor, and Linda Robinson, who's a pharmacist in Windsor. We sat down, and this looks very daunting, I realize, but don't get fixated in the details. Just understand that this is a tool that we've tried to introduce in clinical settings so that it's sort of a checklist to make sure that people who help and assist patients and clients with HIV to make sure that a lot of these things are looked at. And it runs the gamut of the usual things that you would think of in terms of medications, allergies, vaccinations, but also more subtle things that I think get left out in terms of employment, benefits, how are people being, where is their income coming from, where are they living, how do they get to the clinic, substance use, sexual health issues, spirituality, mental health, activities of daily living, and then just some basic nutritional issues, smoking cessation, making sure that certain maneuvers are being done, like pap smears, mammography. This is something that I think we were forgetting to do in our women patients with HIV, just simple mammograms, colonoscopy and colon cancer screening. A lot of these things we just didn't think about doing, so this is sort of like a reminder to make sure that all these things are being done. And then this is sort of another daunting list, and this is just making sure that certain maneuvers are done, sort of some nitty-gritty of smoking cessation. How do you ask the questions? How do you assess for cardiac risk? If someone potentially has diabetes, how do you diagnose that and ask the questions about that? What are the blood pressure targets? Chronic kidney disease, which is becoming more prevalent, and what are some of the issues there to look at? And other comorbid conditions that we see a lot of in terms of hepatitis, osteoporosis, and bone disease. And then this is sort of the basis of where a lot of our recommendations have come from, basically preventative annual health exams from the United States, from the Infectious Disease Society, for example. Canadian family physicians have guidelines. There's nutrition guidelines, there's smoking cessation services, and then the various guidelines in terms of diabetes management, high blood pressure management, and chronic kidney disease, etc., etc. So how do you implement this tool into real life practice? And this has become a big challenge, I must admit. And I've been on the road to various AIDS service organizations, to different HIV clinics, to patient groups, trying to sort of sell the importance of this or the need for this. And we've invited all practitioners to use this tool, whether it's physicians, nurses, nurse practitioners, psychologists, dietitians, OT, PT, social work. It's really, I think everyone can kind of look at this and say, I can work with the client on this, and the clients themselves can actually request some of these things, and that's where I think there's been a lot of popularity in terms of clients coming to us saying, these are things I was told should be happening. So we have this tool on written tear-off sheets. We have it on a cardboard. We also have it in an electronic medical record. So, for example, at St. Michael's, we have it in our electronic medical record. I'm trying to convince my colleagues to, input it at least once a year and try and address some of these issues. And it could be utilized within an interdisciplinary team. I think that's the natural setting for this. But it could also be used for a solo practitioner to kind of guide them along. So feedback to date, and again, I'm not a researcher, I must admit. I'm trying to get involved in various research, but it's difficult to be a clinician and be an adequate researcher. But the feedback informally and sort of some informal tools has been, this will be very helpful, this is way too much work, who has the time for all these questions? And thank you for making my doctor look at me beyond my viral load. It's been from some clients. Do I have to do this at every patient visit? I think this is key to addressing the issues that matter to patients. So that's some of the feedback. And really next step is a more formalized sort of research looking into this. And I'm in discussion with some more research-based colleagues to sort of see who's using this in terms of utilization patterns, who's using it, how are they using it, when are they using it, what are the settings it's being used in, has it led to any changes in clinical outcomes, and has it led to any changes in practice. So that's sort of next steps, and I apologize that I haven't presented this in a formal research sort of protocol, but this is my intent down the road.